Hello, hello, hello. This is Truth Be Told. This is Dr. Walter Aka.
I'm Dr. Leroy Horton.
And we have the pleasure of having two amazing guests with us today, Dr. Lynda Dean-Duru and Dr. Krystle Dean-Duru.
Sisters, right?
Yes. Yes. See,
I guess I'm gonna have to accept that now from now on.
So the sisters are not the sisters are on, but no, I'm excited. I'm excited because they're doing something that I don't think a lot of people talk about. They're doing something that I think is so beneficial for just pediatric dentists to know, for kids to know, and for kids to be helped, and for parents to know. And that's something that I just said. I screamed. I said, "You got to come on the podcast." And the funny thing is, Dr. Krystle has actually been on the podcast in the past. We'll call it that, right? We'll call it the past. But I wanted her and Dr. Lynda to come on to basically shed light on this topic. And the topic that we're going to be discussing is craniofacial development, breathing, and all the stuff that's associated with that. People don't talk enough about that, and so can you guys please give us a little bio, a little breakdown of what happened?
Or just how we started out. Well, I'll start off because I'm newer, but I went to undergrad in Columbia University. I did dental school at VCU and completed my pediatric residency at Interfaith in Brooklyn. And I've been practicing now, I will just say practicing pediatrics since 2015. But I've been in this what I'm calling a new residency of airway health, breathing, guided growth and development, infant care since 2018, so about 5 years now. And it's been an amazing journey, amazing rabbit hole to go down, and I've seen a lot of miracles happen. And
Well, thank you. All right, I've been a dentist a very long time. Let's not just go into that part.
She really means like 6 years.
Yes, that's right. I graduated from University of Benin, Nigeria, which is where I'm originally from, and then came here. I did the general practice residency at Howard University Hospital and my pediatric dental specialty at Children's National Medical Center in Washington, D.C. And so it was a regular pediatric dental practice, although from a training at home where, you were training as a medical doctor as well as a dentist because you could be the only DR in a 50-mile radius. And so that kind of influenced how we practice. And my story about joining dentistry was my little brother being in pain. And so finding out that he didn't even have to have that dental abscess that caused him pain made it so that we practice a lot more proactive prevention. And so getting into this world of airway and sleep for children came by a little bit with serendipitously because I'm recovering from sleep apnea myself. But it happened that I was generally healthy and suddenly went to party in Miami, had to leave the party because I wasn't feeling well. And that not feeling well turned out bronchitis that I couldn't get rid of. Doctor to doctor, I was being treated for Lyme disease, and I knew I didn't have Lyme disease. And then suddenly by the fifth doctor, she took one look into my mouth and she said, "Oh, you have sleep apnea." My eyes went big like this because I'm like, "What do you mean?" And she sent me for a sleep test, and she was right. I had moderate sleep apnea, and I got on a CPAP. The symptoms of fatigue, anxiety, brain fog, all of them went away. And so I wore a CPAP for about 7 years and it was working well, and then it stopped working. And so my symptoms were coming back, brain fog again, fatigue, unexplained fatigue, and all of that. And what am I going to do now? So my options were to have my jaws broken, and I didn't want to do that. And so in researching for myself what to do so that I didn't have to have surgery, I came to another realization that, sleep apnea is totally preventable and it is treatable. And a lot of it had to do with how well your jaws and your face grew. And the signs are there as early as 2 days old. And by that time, my eyes went further back into my head. Oh my goodness, I see babies as young as 2 days old for breastfeeding support and infant tongue tie releases and all of that. And, all those signs are there. Those are early signs of function of how the tongue works. And that can drive how your craniofacial respiratory complex grew. And if you knew, you could treat, you could prevent, you could redirect the growth of a child. And it was even amazing because I saw pictures of me at 9 months old and all the signs were there.
Well, let me ask you this. Is this along the lines of what they call myofunctional therapy?
Well, that's part of, that's a small portion of it. There's a lot of collaborative care. So what happens is when you don't have good function, then the muscles are now trying to compensate in different ways, and you don't have good tongue function. Everything else is working, trying to help the tongue to do its work.
Gotcha.
Yeah.
Okay.
Well, I'm going to start off by saying, wow, you've already started this podcast in an amazing way. I mean, because think about it. Not everybody's willing to share that story, right? Not everybody's willing to say, because of what happened to me, I need to find a different way so that my patients don't have to go through that. And I know you work with pediatric, but it doesn't matter, right? I know any parent, and no, I don't know any parent that wants their child to go through surgery. So what you're basically telling us is, how do we do this without kids going through surgery? So can you explain to me what it took to start really realizing, like, I want to go this route with my practice?
Well, there's a lot of the research for myself meant I was taking a lot of classes trying to figure out, okay, how do I even, what can I do? Because surgery was just not an option for me. And it was, I believe it was AAMS, it's the American Academy of Myofunctional Sciences. They had a conference in Chicago. I want to say it was in 2017. And Dr. Gil Minot was there, Stanley Liu, Matheson, that's all the big names in sleep all over the wall came for this conference. And I happened to, I don't know, something made me just register and go. And so it was at that conference that Dr. Zarusagi was there. Actually, it was the first time I heard him speak, Dr. Cutlow. It's like everybody was there. And so I'm going from one class to the next and another class, and everything that we're talking about, we're pointing to your face, pointing to your jaws, pointing to your tongue function as how those determine how well you breathe and how well you sleep. And also finding out that this can be changed. You can actually retrain your body. And most importantly for us, it could be prevented. So that's what I came back, and before then I was doing general orthodontics, interceptive orthodontics, early phase orthodontics, and I was feeling good, like I was making room. But I didn't think anything of, why did I need to make room in the first place, right? Because if your tongue worked well, if you breastfed well, your body should make you room. Your jaw should be wide and big, and you have space for your teeth. And if you were eating correctly, if you were chewing good food, you help with muscle function, and the muscle and muscle will determine where the bone goes. So you have room. So for about a year, I didn't even treat any orthodontic cases because I was like, okay, this is different. I helped kids get their teeth straight, but they came in. Now, all those signs that we used to see, they were snoring, they're having pain. You look at them, they have dark circles under their eyes. It's first thing in the morning, they slept for 10 hours and they look tired. And so it's changed the perspective. And so it's a lot of training. It was a lot of education. It's like going back to dental school, period. Actually, it's probably spent more than, more money on training on how to do this and understanding to do it well than we did for dental school. And that's probably, I'm taking her along with me.
Yeah.
When she first got to the practice, she said, "Mom, you talk too much." And I was like, okay. And so now I say, "Krystle, you talk too much," because now she understood what we were looking to do. Because for most parents, they come in, they came for their teeth. The most they can say is, okay, it's crooked, fix it. But when we as a practice are going, no, it's beyond fixing the teeth. We want to figure out why the teeth got crooked in the first place. And we want to figure out why your kid's not paying attention in class, right? Because if you're not getting good oxygenation and good sleep, you're not going to be focused during the day. And so a lot of the children, they get diagnosed as ADD, ADHD, meanwhile, they just haven't had good sleep because those symptoms kind of mirror each other. So really.
Well, let me interject. That's a great point that you brought up as far as the sleep, because I think in one of the last episodes, when we had a provider that was talking about TMJ issues, there was this statement of, before I do, let's say, what was it, repeated Botox, the patient has to get a sleep study, right? Is this something that even with kids, before you get into a certain point of your treatment, that you will collaborate with other providers, like their medical or sleep specialists, to kind of fine tune your treatment strategy?
So you want to speak on that?
Sure. Yeah. So the answer is yes. And the answer, what we started to see is that we have to kind of quarterback these referrals. So the sleep study or sleep screening, which is typically what we do before we do a full sleep study, or before we send out for a full sleep study, it helps us see what the body is doing when it's supposed to be relaxed, when the child's supposed to be making growth hormones, and the body's supposed to do what it needs to do, clean out the lymphatic system, clean out the brain of toxins and things like that. So you do have to do a really good diagnosis or a really good gathering of data to be able to say, okay, yes, I need you to see this provider. I need you, because a lot of times too, the providers are like, why are you sending them to me? I'm going to do surgery. That's not the case. Say for an ENT, we need them to breathe through their nose. If in our 3D image, we're seeing their adenoids and tonsils blocked, we need them to at least get an evaluation, not necessarily do the surgery, because we want to collaborate with the provider, any of the providers, to say, hey, this is what we're going to do to help your job get easier, but we need you to do this or we need you to do that. So having a sleep study is one aspect, because there's so many things that a sleep study can tell you, and not just the AHI. That's for insurance company. Even the inventor or Dr. Guilleminault, who came up with the AHI, he himself said that, I don't even know why I did that. It's so arbitrary, right? Because there's so many other things that come into play, and that includes the neurology as well of a child. So
can you let us know what AHI is?
So the apnea hypopnea index. So this is how many times in a 10-second period throughout the night a child stops breathing, or anyone stops breathing. And so for children, sometimes it's called, they'll say it's mild. Say if it's like under 4, right, or under 5, it's called mild. But if you think about it, they've stopped breathing throughout the night for a certain amount of time, under 10 seconds.
10 seconds or more.
10 seconds or more is when it's recorded. But there's a 9.9 that occurs, and that sometimes occurs throughout the night, or they're having what we call respiratory. There's certain indices, other things that are seen in a sleep study that show that, hey, they're actually not getting restful sleep. The AHI is the end stage. OSA is the end stage of the entire disease, right? It's a spectrum. So that's why I said the sleep study is just like an indicator of like something needs to be done, but it has a lot of information that allows you to see that, hey, there's more to it than just like that number that the insurance company would be able to use for a CPAP machine.
I see. So in a quick and concise way, what does it look like from the child coming in the door, new patient, to you identifying, going through the process of diagnosing, and then the treatment sequence of, let's say, a complicated case? What would that look like in less than a minute from A to Z?
Oh, okay, hold on. No, he said a lot. No, let's be fair. Let's be fair.
We can dive into it, but just bullet points, so that way we can have a framework of how to build the questions.
Okay, and that's fine. That's a legitimate question.
That's a tough question, though.
Because it's taking us time, right? Even as a practice to iron out the kinks of all of this. You get there, you get all this knowledge, and you're like, oh my God, how are we supposed to make this into something that's chewable for not only us as practitioners, but patients and the team members. So typically what we do, we call it in our program, what we call is Growing Healthy Faces. And typically what we do is have an evaluation. We call it an assessment. And the assessment includes videos, posture, lots of pictures, lots of measurements. It's a 2-hour procedure or 2-hour appointment. And we take a 3D scan. We give them to take home a sleep screening, a HRPO is what it's called. And then with all that data, because the 3D image gets read and all of that, so that, because we're not full radiologists as well, but we do know what we're looking at. All of that is read, all of that is analyzed not only by us, the radiologists, everything, and then the patient comes in, they can come in, or we do a virtual treatment planning consultation, right? We have a full, very detailed PowerPoint, because they can send this to their anybody that, like I said, we want to quarterback the whole treatment, and then treatment starts. And oftentimes that involves releasing ties, oral ties. That oftentimes involves what we call desensitization, because sometimes they're young, sometimes they have special healthcare needs, and we have to calm down their nervous system before we put anything in their mouths. And then it involves certain types of appliances. We don't like to sit and say which appliances, because there's so many tools in the toolbox. What we do say, and the type of appliances we do use, they're biomimetic, meaning they're not blocking the tongue, which allows the myofunctional therapist to be able to do the work while we're working. It allows the tongue to be able to be free while the face is growing and things like that. So, and if we do have to, in certain complicated cases, because not everything is is black and white. Some kids come in and they have the teeth everywhere, and they're typically extraction cases. We're not doing any extraction. So sometimes we do have to temporarily use some growth guidance appliances that help to make more room. So a big part of it is our philosophy or pillars of treatment, which are structure, function, and behavior. And that's that structure, making room, but also the function. That's the function of the muscles, function of the tongue, and the facial muscles, and on all of that. And nutrition, and posture,
and neurology.
Right.
Those are very, very holistic, very comprehensive. It's not.
Yes.
Yeah, comprehensive is a good word. Yeah. And how long would this take? Is this a years upon years, or what's the time frame in general?
Usually we'll say take 12 to 24 months actively. And so as you're guiding the growth, we tell the parents we're still looking. We're looking at what we're looking for is the body to take over its function, because inherently the body can heal itself. So we're looking to remove obstacles in whichever ways we can, so that it takes over that function. So from myofunctional therapy, you get good tongue function, because eventually your brain, the cranium, is looking for good functional swallow. And that's what helps it to grow. That's what helps it to send messages through the fascia and all of that. And so, generally within 3 months, a lot of parents start to see changes. So for a lot of the children, the first things we notice is that they're coming bright. The circles under their eyes are gone. The dark circles are gone. So, and I start being very joyful, because that tells me they're getting good restful sleep. And but eventually they start making room for their teeth. And because the appliances we use were very gentle, because you can't force the bone. If you do, you're now moving all the cranial bones in different ways. So really important that we respect the body and get the neurology, get the brain comfortable and happy, so that it's able to help you grow like you're supposed to.
Yeah.
Let me start from, and we covered a lot there. I'll be honest. Let's break it down from the beginning. Ready? I have a child. My child is a little cranky when they wake up. Like you said, I notice the dark circles because I've watched your Instagram. I've watched a lot of stuff that you guys put out there. And I'm like, okay, I need to come and talk to Dr. Krystle or talk to Dr. Lynda, right? So Dr. Lynda, what are the signs that I need to look out for as a parent to know that it is indeed time to come talk to you? Or is it that my kid is just, on social media at night and I just didn't know this? What are things that I need to look out for so that I know hey, it's time to come talk to you and get your expertise?
Well, that's a great question. And I generally will say, from the time you come home from the hospital and you spent a day or two trying to nurse, and you start having trouble nursing, meaning there's pain when you try to feed the baby, or the baby is falling asleep on the breast, or is not able to latch properly on the breast, then yeah, you need to come see us. And
or mom decides on a bottle.
Huh?
Mom decides on a bottle, right? She's like, I don't want to, because sometimes they don't relay like what's going on for them.
Yeah, yeah. Or they say, oh, I can't make milk. You know, if you make that baby, you will make milk. The only reason the milk is having difficulty coming through is because the baby is not suckling, giving it that reflex so that the milk your brain can keep making more milk, right? And then, or they get to about 6 months of age and you're starting solid food, and they're choking on the food, they're gagging on the food, they don't want to chew.
Fussy.
Generally they're already very fussy before that, or colicky, or projectile vomiting, or just spitting up. Spit up is not normal. And so even a little bit of it is not good. So whenever baby is sitting up, then you need to have someone check that out, someone who understands, check that out. And so now they're getting to be older, they're getting to be about 1 or so. And at that point, they have teeth in. Obviously, we're still dentists, so we're still going to talk about taking care of teeth and things like that. And so if the teeth not coming in, or they're coming in and you start noticing they kind of turns every sideways or somehow, there's a problem, because that means that their jaw is not growing like it should. And you're noticing now they're not talking, and they're not walking like they should be. They're not meeting their milestones. It's possible that their tongue function is not proper, because the tongue is attached all the way to the tip of our toes through body fascia. So if it's being restricted and it's not functioning properly, then your whole body can't function like it's supposed to. And so now they're getting to be older, they say they're terrible twos, they're not sleeping, or they're tossing and turning when they're sleeping, or they wake up in the morning and the bed is like a tornado hit the bed, or the kid is laying the other side around, or laying with their butt up in the air. So that just tells you that they're having difficulty being able to get good oxygen through the night. They're not breathing properly. They're just trying to find
They're looking for it.
Yeah, they're looking for a good breath. And so those are things that we want to see. Or they're picky eaters, or they just tantrums. They just, they're quiet this minute, and the next minute they're all over the place. We need to, that's a time to call us as well. Or they can't focus in school, or they're having trouble with speech as well. They can understand you. They want to follow directions, but they're not telling you the words. They can't say it. Or when you come back, that somebody say, oh, they said something. So if there isn't enough room in the mouth and the tongue is having trouble, it's too much work for them to be able to say the words that they need to say.
And typically you'll see a kid that's been in speech therapy for years and years and years, right? We should not be in speech therapy for that long, unless they have an actual, understand comprehension disorder or anything like that. And that you can test. The other thing is typically if, like we said, at school, they're disruptive or they're lethargic, things like that. Those are things to watch out for as well.
I almost feel like that's almost every kid.
Right. So
if you spend time in a classroom, that's almost every kid.
You're precisely right. And that brings us back to it is everybody. We used to be like, oh, maybe it's everybody, because we're not eating, we're not chewing, right? A lot of our foods, the way we used to, a lot of our foods, we're taking them from a packet. And in order to build our lower jaw, we need to chew, right? Our face grows from the base of our cranium. So we need to chew in order for our TMJs to be developed properly and our lower jaws to come forward and get space to breathe. Our airway is right behind our tongue. So we're not doing the functions as we used to do. So a lot of kids, and it's getting worse over the years, right? We're not breastfeeding. I mean, I think there's now a bigger push to breastfeed. So that's why there's a lot more understanding, like, oh, something's going on. But we're not doing those actions. So we're seeing it in our generation now due to the epigenetic changes that we're seeing. So you're right, it is everybody.
have you had patients or even other colleagues look at you guys and say you guys are over treatment planning?
Right.
Right.
We of course. And the thing is, a lot of the treatment plan or a lot of the treatment is very conservative, right? A lot of it is the extra work is making sure that we're seeing and getting to the root cause. So that may seem like, oh, is this nuance important? It's important because parents live with their children and they see it and they know something's up.
Right.
They also know, oh, I wasn't like this. Sometimes a lot of it's projection, and sometimes is, we do have social media, we do have, video games, we do have a lot of things that are causing the sleep hygiene to be worse,
Right.
but it's exacerbated by how we're growing and how we're functioning, right? So that's part, I maybe even add that as part of like our pillar, like that hygiene, and that's the emotional and psychological aspect, because that then causes more stress in the body as well, which doesn't help a child to grow. So yes, it's a lot of our colleagues at first say that, but then the research it's insurmountable research now.
Well, the therapy might be considered conservative, obviously, because I had a good friend of mine, an orthodontist, was telling me that nowadays you have to consider myofunctional therapy as opposed to the 4 on the floor mentality that we had before, because we are constricting airways, especially in younger children, right?
Oh, whoa.
But
that was admitted?
Oh yeah. Well, yeah. Well, but here's the question. Here's the question. Because although you do say the therapy is conservative, is the price conservative? Because I was going to say, because I had a colleague she was an associate of mine, and she did training for myofunctional therapy with this big time doctor out of California. And the price tag that they were recommending for this therapy was, upwards of 20 grand. So how do you convince a parent for potentially non-insurance covered treatment of this magnitude? As conservative as it is, it's also a little pricey.
You're absolutely right. It is pricey, but imagine that you're doing full architecture of the head and the brain and the mouth, essentially, right? Or of the face. And for us, we follow them from when they start to when they stop growing, right? Because they stay. I don't know if you have
I was just gonna say too pricey compared to what?
To what, right?
So yeah, I understand where you're not to make light of it, that having been in the medical system, having had a CPAP, okay, and you go to bed looking like Darth Vader, it's not romantic. So, let's just even go there, to start. And before you, mind you, sleep apnea is the end stage. Before you get to that, there's the obesity, not able to lose weight. There's the diabetes type 2, and there's a whole lot of anxiety, which they're probably having to pay a therapist for. And they do that like readily, just like this. Meanwhile, you could get your child breathing well, sleeping well, and make them a lot less anxious than they would have been otherwise. So yes, it's an investment. And, some parents, and even some of the parents that you don't think can afford to do it, they find ways to do it. And so we do have a lot of options for it. We would like to get all the money all at once, but it's not about that. For us, it's a mission. And for me, especially, I don't want to 20 years hence have a kid that passed through this practice have issues that they could have prevented and look back and say, I was their dentist or we were their dentist. So for us, it's a legacy issue.
Right.
Yeah. So what is the price range for something like this?
It could be as high as 30,000 to as low as 10,000. Depends on what you have to fix or what is gone wrong. How early, the earlier one, that once you start early, there's not a whole lot to fix to get the body back on track. But when it's gone for a long time, then there becomes more intervention that is necessary.
In all honesty, I will say that, we talk, Dr. Horton and I, we've talked in the past about if you are going to do a full mouth rehab for all on fours, you're paying $50,000, and we don't blink twice about that, right? And we're taking we're taking all their teeth out and doing all this other stuff. So I think preventative is just a measure of like what you want, what you find to be important, right?
Yeah.
I can guarantee there are people who are like, I'm not putting a whole car price in my mouth all
Yeah.
because I didn't brush my teeth, I didn't do all this other stuff. But we're okay saying to patients, you need to pay that much, right? So to me, price is relative.
Yeah.
What I want to know is, do we get something out of it, right? And we're going to start from the beginning. When it comes to kids, you were talking about tongue tie. Can you break that down as to, mother has a newborn baby, they're excited, and then they go through the struggle of, like you said, throwing up or baby spitting up, and they're not feeding right, and mom is getting mastitis and all this other stuff. Can you tell us exactly what to look for as a parent, and then also what you guys do to correct that?
That's great question, and a very important part. And again, just like we said previously, the first day, second day after birth, everyone, you and the baby, you're trying to get used to one another. And usually the first intervention should be with a lactation specialist, a lactation consultant, because they can show you maybe positioning and things like that. And after you've done that, and you're having pain when you're feeding the baby, or the baby is sliding off or falling asleep on the breast, or they're not able to latch properly, then there's a problem. And so they need to come, and part of it could be something that mimics a tongue tie. It's not always a tongue tie. The birth experience, I know, right?
Okay, wait a minute. And see, now you got me confused. So is it a tongue tied or is it not a tongue tied, right?
No, it's not always a tongue tie. Maybe some things can mimic a tongue tie, but there's tongue function that is being impeded. Yes, always the tongue function is impeded, but that impediment is not always a structural tie. Okay, so what I was going to explain is that the birth experience, just passing through the birth canal, is a lot of turns and twists on there. And sometimes we have to help labor to start, like things like Pitocin, or even you have epidural. And when you have those, then you have more compressive forces that is now helping the baby to push through, some more unnatural forces. And so our skull, as you know, when they're coming, there's 22 bones in here, 14 of them are in the face. And so they're all in little pieces, for lack of a better description, they're all connected by sutures. And within between those sutures are fascia, which are like little soft tissue areas, and that have nerves and blood vessels and all of that through them. So you imagine that being compressed in that little space. So a lot of that compression goes to the back of the head, right here at the back of the neck, where the coronary, there's 4 pieces of the occipital area. And so those 4-piece area is very important because there are 2 important nerves that pass through there. The one's a hypoglossal nerve, which supplies the tongue, and the other is a vagus nerve, which is for rest and digest. So if they get compressed back there, you're going to have impaired function. And so that's why it's important that you now have to distinguish, is it a structural tie, or is it because there's compression and tension so that the nerves are not able to do their work, not able to supply good motion, that the baby is not able to feed. And so they come after they've seen the lactation specialist and they get to us. We have to make that distinction. And so we're going to do an exam, and sometimes you can see a tie that's down to the tip of the jaw. Okay, there's a structural tie. You still want to make sure there's not a lot of tension in the body so that the nerves are working properly before you get to release it. But other times it doesn't look like there's a tie there, but because there's a lot of tension. So the first thing to do is to release all that body tension first. And so we'll do that with a non-surgical laser. It's called baby laser, which is a 1064 nanometer wavelength. I didn't ask
with the Platona, yeah.
No, it's okay.
So the TENS laser, yeah.
No, not TENS. It's the 1064 nanometer
wave.
So that the wavelength is what's important because it gets down to the nerve. right? So the lasers that we use are the X-rays and the Photona, and they have that non-surgical Nd:YAG
Yeah.
wavelength.
Yeah.
And so the laser that you guys are using is different than maybe another laser that another office uses?
Well, it's not just us, but there's a wavelength. There's a wavelength of that matters for it. There's certain different wavelengths of lasers do different things.
Yeah.
And so for this particular one, you're not cutting. It's the light itself that's penetrating deep into the fascial layer up to where the nerves are. And that's what allows it to loosen up the hyaluronic acid in the fascia so that the nerves can actually move and supply the areas they're supposed to go. I know it's mind blowing.
Well, no, now I got more questions. So if it's a physical attachment, like meaning that you can see that that there's a physical, restriction of the tongue,
Yes.
you're using a laser to cut, correct?
We would use a laser to cut after we've get the body ready first.
So the understanding is that the tongue is connected to the tip of the toes to body fascia. And so if I'm affecting the tongue, I'm affecting the knee, I'm affecting the shoulder, I'm affecting the neck. So if for a baby especially, right, who just came in, everything is tight. So I can't just go in there and just cut. I have to make sure that there's tension relieved other places in the body. So I'm seeing the distinct fascia or distinct frenum. And the frenum doesn't move. It doesn't stretch. A tight restricted frenum does not move, does not stretch. And it's made of complex fibers. It's not actually just fascia, right? So you can make it distinct by being able to melt the fascia, the healthy fascia, or making sure that the patient or the baby has body work. Something like body work would help, and then you can see the actual restriction. And that's why it's a more conservative cut, because you're not just cutting, right? You're not just releasing. And so they're two different, or they're types of lasers. They're the cutting lasers, right? You can use a CO2 to cut. You can use an erbium to cut. I don't recommend a diode, but but again, tools, right? And then you have an Nd:YAG, which first allows you to see what you're cutting, to be honest, because you're being able to melt away unnecessary restrictive fascia, right? Along with having some body work as well for some.
And what is body work? You keep saying that.
So body work, this is where it goes beyond us, right? Because the rest of the body has that tension that we're talking about. And so being able to go to we call it whole body worker, a cranial osteopath, an OT that's well-versed in the tongue and well-versed in the mouth and the growth of the face and in babies, chiropractor, a specialty like these, they have to be
craniosacral
therapist,
sometimes some massage therapists as well.
So someone who is well-versed in understanding how to relieve tension in the body, especially in infants and in the mouth, is important, because then they can help distinguish what is an actual tie from what is mimicking a tie.
So devil's advocate, just to be fair to all the listeners.
Yeah.
There's often a lot of holistic naturopathic doctors that'll say, this nerve point is connected to your toe, to this, to that, so forth, right? If you're saying the tongue is connected through fascia all the way down to your toe, how do we know that the problem is not originating in the reverse order? And how are you so sure it's the tongue that's causing everything and not the toe, or not something along that track?
Excellent question. I'll answer some, and then Dr. Lynda will, because she's the guru. But first of all, there is a beautiful dissection on YouTube of deep line fascia that shows that tongue being connected. So you already see the tongue is connected to the tip of the toes to body fascia.
But right? The other way around too. The toe's connected to the tongue.
Yes, exactly.
So it's not one direction.
And the reason why I bring up the tongue being the most important part of the body is because it forms the second organ to form after the heart, right?
Before the brain differentiates.
Exactly. So, and it forms 4 weeks in utero, right?
4 weeks in utero is already peristaltic.
Right. So it's one of our most important functions that we have. So it's likely, I'm not going to say that's the only thing, right? And that's another reason why we take a lot of care before we cut. It is most likely the issue because it's one of the most important
based on its embryological formation.
Yes.
and function.
And function.
But and function, obviously, but that
and lots of data.
you can see where someone would say that sounds like conjecture, right? Because the
there's lots
organ
of
was
data.
formed first, it
Uh-huh.
must be more important, or it must be supersede any other part of the body per se, as far as trying to do detective work to see where an issue is stemming from.
So if it's forming first, and the brain, like the way our brain works and the way our function works, it stacks. Like our function and executive function stacks, right? The more we learn something at a basic level, or the more we pass through certain reflexes, the more executive functioning we have, right? So the tongue plays a very, very important role in that. And there's a ton of studies that can be supplied easily. There's a ton of studies. So it's
no conjecture.
Yes, exactly. So
Studies that show what?
That's no conjecture at all. So
studies that show the importance of the tongue and then the rest of the body, and why it governs a lot, including swallow, including the glymphatic system, meaning the clearing of
draining of the waste product from the brain.
Right. So it's one of those things where as scientists or as doctors, we now, after reading different types, not just dental research, but different types of research, you now put the pieces together. So like I said, I didn't say 100% the toe wouldn't be first, but if we were to be treating patients, or if we were to actually making educated guesses, or which we're not, you would start at the tongue. Right, you would start at the tongue and a tongue function.
But I see the point that you're making too.
Right.
If it could be the restriction on the knee or the toe or the hip that's causing the tongue not to work as it can. That's why we want to do that additional work, making sure that you release the tension, you have the baby, because you're non-surgically first, because you can't do an irreversible procedure and hope that it works, which is what some people do, because you just go to cut the tongue and maybe they'll go home, they feel okay after they nurse right a little bit. And then, 3 months later, they're back, all the symptoms are back. And because you haven't fixed the real problem where it started from. So that's a great point. So,
another reason why collaborative care is important, and being able to talk with these whole body workers who have also studied for many, many years and been, very educated in what they're doing.
So to, I guess, follow up with Dr. Horton. Sure. So do you guys do the whole body first before you do the tongue? I don't want to call it laceration, but like the tongue
release.
Before the release. Yeah. You do the whole body work first.
Yes.
And, so and if you realize that the whole body work part, kind of is it always one of those where you have to do the tongue release, or is it just like the whole body helps with the tongue release, or can it just be like the tongue, the whole body? Hey, that fixed what we were looking at, and then we'll stop there.
Yeah, sometimes. Okay. Yeah.
What's the percentage? Do you guys know the percentage?
I would say about 30%.
Okay.
About 30% of the kids, of the babies, don't need to have a cut.
Okay.
But it's intense body work and then non-surgical lasers, and there's certain symptoms or certain things we're looking for to help them make that decision, or help that baby make that decision. When they're coming and they've done the exam, if I've done the exam and they don't have a high vaulted palate, that tells me that tongue function was doing well for a neuro. And so it has to be something like perinatal period that has caused this. So we can further investigate what obstacles can we remove so that this mom can breastfeed painlessly or pain-free, and the baby can actually be okay getting the breast the whole way past the areola without having to swallow air, getting good vacuum seal so that they can swallow properly without swallowing a lot of air, because that's part of what makes them also spit up.
I'd have a question, because back to
Sure.
the embryological, I guess, timeline. I'm thinking of the diagram of the homunculus. And if I remember correctly, although the tongue is shown to have, somewhat of a higher dedication to the brain's sensory cortex, it's not by far the biggest, right? The lips are proportionally bigger, the hands are proportionally bigger. So how does that, I guess, line up with this notion that the importance of the tongue is, that we can conjecture that simply because it's the secondary or the second organ to form after the heart, or structure to form after the heart, is that much more important?
Maybe I don't know what the conjecture.
Yeah, I think you might have to explain that,
because I'm just
ask that question a different way.
Yeah,
Because I mean, I get what you're saying, but
well, I guess the question is that in trying to figure out why the tongue is given the priority as, I guess, the suspected culprit in this, full body connection with the fascia. And it was said that it had to do with partly with the fact that it's formed second embryologically, which I don't remember that, but
it is.
And that the brain stacks in its neurological, I guess, development, but we know that much more of the sensory cortex is dedicated to other parts of the body.
Exactly.
So how can we put that great of an importance? And how is that actually proven via studies?
Yeah.
Because it's one thing to say that there's a lot of studies. Could you refer us some? Are these high level systematic reviews, or are they just kind of anatomical reviews?
Well, it's in the literature, the medical literature and biology. So that's not disputable, whether the tongue is a second organ to form or not. That's not disputable.
Well, I'm not disputing that.
Okay.
I'm disputing what you were deriving from that.
Oh, okay. So great point. Thank you for bringing back to that. So when the tongue, because of its peristaltic motion, it's also helping with cranial motion. Are you familiar with that word, cranial motion? Primary restoration.
No.
Okay, so again, the skull bones, all those spaces between them are moving, and they're supposed to move with each swallow. So that swallow, that pressure from the tongue is what gives it motion, and that motion is what helps it to distribute information and also drain and cleanse itself. Right. And so when we studied anatomy in school, we had cadavers, right? And everything was frozen, everything was like fused. And so we came out with that impression that, okay, the human head is kind of fused, it's stuck together, it doesn't move. But osteopathic physicians always knew that that was important, because with each swallow, with each breath, it does this, it moves, and it moves even up to 10 minutes after someone expires. And so that tongue motion is part of what helps that respiration, the primary respiration, breathing. So,
and also when you brought up the homunculus, you're talking about the sensory cortex. There's also the motor, right? And so that's the tongue has a few, it's made up of 9 pairs of muscles, and then a lot of nerves, but that are governed by motor and sensory, right? So you're absolutely right about the homunculus and our brain's perception of the sensory cortex, but you have the motor cortex as well, which is just as important. And I think breathing.
You're saying so it's more integrated with motor nerves than other parts of the body. Proportionally?
It's not a more or other. It's function. And when we talk about the function of the tongue and how it works or how it affects our breathing, that is on a highest level of importance, right? It's actually at a high importance on how we breathe, sleep, function. It's of utmost importance, the tongue is, versus say the toe.
More like, say, the diaphragm?
Yes, actually. The tongue actually is one of the we'll call it like the rudder, right? So the diaphragm is extremely important. Yes, it's very important because of the way it's shaped and the way and what it's doing for us. But if your tongue is blocking your airway, if your tongue is blocking your airway, especially when you're sleeping, you're not going to be able to get proper respiration
That's when you
to
use
your
your
diaphragm
chest
and
to
use your
breathe.
chest to breathe and not your diaphragm. Right. So there is an order of importance. I don't even like to say that I don't like to say that in what do we call in physiology, because so many things work in concert with each other, but the tongue is extremely important.
There's a functional swallow that helps you determine how well you breathe and how well you sleep. And so, and that's one of the goals of my functional therapy.
Let me get away from the science, because not everybody that listens to us is science based. In all honesty,
we're like, this is great. We love
no,
this.
No. Listen, I'll be
Awesome.
honest with you. This was great,
should
but
grab drinks and talk about it more.
I listen. I can already hear.
Yeah,
I can already hear my brothers telling me that this is getting boring. So I can already hear my brothers saying this. I'm gonna be honest. Right. Let's go ahead and let me ask you a question that maybe everybody can relate to. Is how you guys talked about appliances for kids. The question I have is, you can't even get patients who are adults to be compliant with appliances. So how are we doing that with kids?
Well, luckily we were trained in pediatric dentistry. So
right. No, do you see what I'm saying though?
The most awesome thing. But the beauty about kids, they're actually, I find them even like more fascinating than adults, because once they start feeling better, they like 4-year-olds, I need my thing back, right? Yeah. Some of it we use Invisalign first. They're like, I need my thing back. Just the feeling of it, like they understand how they're feeling. And that's part of why we even like what we're doing now, because having an understanding of what your body's doing early on allows you to catch things early. It's like your own education of your body. Then you know what to do, where to go, on how to treat yourself even, right? And what practitioner versus like, oh, give me medicine, right? And kids, when you start teaching them early, that integration in their minds, in their brain, it becomes where it's even more, the kids are telling mom, I don't want to eat that. That's not what I'm supposed to eat, right? And so that education early is part of this intervention that we're doing versus just giving them appliances. We're educating as well. So yeah, with kids, I'm not going to say it's easy. There's nothing easy about anything that we're doing. It's exciting though, because of the changes that occur. And then it's like you're building, it's the building blocks. And so at some point they start feeling it on their own. The harder group of people are the early adults, which are the teenagers.
And then you guys pass them on to us.
They still come back, so nobody leaves. So yes, we like to, but no, we love them as well, because they themselves, once they get hip to it, then they're also as compliant as possible. But we do our best to try to make it as fun as possible, and
get them involved. Even from the little ones, because everybody wants to be in charge. Right. So, and then some other times the parents who are having difficulty are the ones who are trying to impose that, hey, you got to do it like this. No, you got to make the kid feel like this is their decision. There's only two choices, one or this. Right. Even if you give them the same choice, it's like you're giving them a choice. They feel like they're in control, and that's very helpful for them. So yeah, Dr. Krystle is right, because when they get the appliances out, and we use biomimetic appliances. It's the Invisalign first to just help to create oral volume. We use it a little differently from how Invisalign wants to use it. They just making room, but we're also using it in conjunction with other therapies, in conjunction with getting the nerves and neurology going, and also myofunctional therapy as well. And then we use the ALF appliance, which is it's like a surrogate tongue. Again, your tongue has to be sitting on the roof of your mouth for health, so that your lips are together and you can breathe through your nose. That's your ultimate life, ultimate health. And so if the appliance makes you feel like the tongue is up, makes the brain feel like the tongue is up, there's not a whole lot of adjustment to it, but it attracts the tongue up, and it attracts it so that you continue that primary respiration, and they start making room by themselves. They start growing their own jaws, and that's what sustains them, because now they have good bone and good structure, good juicy bone, good structure, so that their teeth can come in a much better position.
Okay, so
Yeah.
I think I've played devil's advocate, so I've kind of thrown the the skepticism at you, right?
There's a lot of people thinking the way you're thinking, so
Right.
Awesome.
so
But what I want to do is get back to your story. So I feel
Yeah.
like both of your stories is fascinating. So you guys are in private practice now?
Yep.
Yes.
Okay. What, as you've transitioned, especially to this part of treatment modalities and educating patients, what do you feel has been your biggest challenge? Because obviously this is stuff that, even in this setting, I mean, we had to get really academic to talk about it, right?
Yes, sir.
What's the biggest challenge in being able to express to parents in a way that's digestible for your layperson that can then translate to acceptance, compliance, and success?
That's a great question, because even for us, we're still struggling with it. And I think the biggest one is a shock that when they come in, they just came to have their teeth cleaned and they just came to the dentist. And now you're telling them something has, the circles under their eyes, the picky eating that they've been having OT for many years is related to something that in their jaws, that their jaws haven't developed well, or their tongue is not functioning well. So that's, I think, is the biggest hurdle for parents to start to accept and go from, okay, but that happened to me, or this has been happening for a long time, and their pediatrician says it's okay, or they're going to grow out of it. So,
or why didn't my pediatrician say something?
or we
Right.
get the ones who get
Right.
upset. Why didn't my pediatrician say it? Or why didn't I've seen this other dentist? I've seen many pediatric dentists. Why didn't anybody else say that? And so having to explain and say, the literature is out there. People in the West Coast and the Midwest, they're a little bit more advanced than us here in the East Coast in that direction, because they're more readily, I think they're more crunchy, so they're more aware of their bodies more than us around this area.
Did you notice Dr. Horton?
Yeah,
Did you
we're
notice
more
Dr.
in our
Horton?
heads, we know.
Did you notice Dr. Horton starts smiling?
Oh,
You just made his day. You made his day. So
oh,
please,
really?
he's in the West Coast, so that you just made his day.
Okay,
You know?
y'all are aware. Hats off, man.
It's the melding of the two different types of medicines, and I know in our area, it's like you said, my pediatrician didn't say, and then other practitioners didn't say. So it becomes like the shock value. We just have to hold space for them. Sometimes it takes 2 visits. We see them every 6 months, and we give out what we call like checklists, or we say, hey, we call it private eye. Take this home. If you notice this, let's have a conversation. We have to slow roll everything. We have validated screening forms. We call it the Ferris 6 with Dr. Zaghi. We kind of adjusted it as well and added a few more things because it's pediatric. And so parents are starting to see. At first we gave a lot of literature, but we're like, we're the nerds. Nobody's reading this stuff. So we're still in motion on trying to make it a bit more digestible. That's why we like educating. A lot of it is educating and educating our peers, to be honest, because we're doing the work of reading the science. We're doing the work of going to these courses led by practitioners who are doing a lot of that groundwork that in school we knew we weren't doing. We get tidbits for the exam, right? And we're just trying to get to our specialties. So it's a slow growing thing, but slowly but surely, especially for the patients that are feeling the improvements, or when they go back to the pediatrician and they've grown so much more than what they're supposed to grow, and the pediatrician's like, what are you doing? We're having now pediatricians refer to us, right? This patient's not sleeping, or a psychologist who has a kid that's just, the parents like put their hand up and they've been prescribed amphetamines for how long? So they come to us. So just people who are looking for different alternatives to something that, or to a root cause approach, that's how it's going. And so just a lot of education, holding space, doing our best to connect the dots for parents, but then also doing our best to educate our colleagues who are oftentimes our friends that the best way to be like it to a patient, if you don't know, is you don't know. But sometimes that doesn't happen. They just say, no, this doesn't exist. They're crazy. They're wackadoos. We've accepted being Fruit Loops in a box of Cheerios, right? We've accepted it, and we know
We're proud of
it. We know we're on the right side of history. We know we're the right side of medicine. And so to be able to, to answer your question, how do we talk to them? We just keep holding space. We keep doing our best. It's a lot of work and dedication, but
let me ask.
And you know how it is even for us as dentists, sometimes it's like, okay, I have to see something. You have to cut something and do something, and something happens. And so this is more subtle, and you have to pay attention and things like that. 2005, when I started using lasers for heart tissue, like cutting cavities without numbing, it was like, oh no, that doesn't work. There was like a buzz around. Well, she's crazy, she's saying this, she's saying that. And it wouldn't work because some of them bought lasers, but they just didn't go to educate themselves. If you don't go to educate yourself, just like anything else, it wouldn't work, or it doesn't work. So it's just being patient and not losing our enthusiasm. Again, the mission is beyond us, really. So this place is going to be known for helping kids be their best, no matter what. So
let me ask you a question about snoring, kids and snoring. Okay, so you go to the pediatrician, and you look in the kid's mouth, and the kids might have like large tonsils. And they're like, well, based on what we know, it's not touching, or that should be fine. We don't want to remove the tonsils, because a lot of pediatricians have kind of gotten away from that, right? Mm-hmm. But the child is snoring. Is snoring, is that a negative when it comes to kids? Or is that something that you just keep an eye on? Or is that like on your checklist that says, hey, this kid is snoring? And how do you know when it's like, okay, this is actually a problem? Versus, sometimes kids have stuffy noses and they snore. It is what it is, right? How do you know the difference? How do you tell parents what to look for so that we can say, this is snoring and this is okay, this is normal, and this is snoring that this is not healthy?
I don't know how we missed talking about snoring anyway, so I'll let Dr. Krystle.
Oh, yeah.
Okay. So essentially, snoring in any shape or form is not normal. It's an indication, it's a symptom. It's the start of what we talk about, that long spectrum of sleep disordered breathing or sleep-related breathing disorders to sleep apnea. And so when, like you said, they've got the large tonsils, but they're not touching, they're still suffering, right? Because large tonsils at this age means there's been a lot of infection, right? It means like the body's doing a whole lot of work and inflammation to fight. So that should already be an indication. So that for the pediatrician, right? For us as dentists, now we're looking at the other parts of the other structures. We're looking at the jaw size. We're looking at where the tongue is sitting. We're looking at
the shape of the palate.
The shape of the palate. Is it a high arch palate? We're looking at the teeth. Are they just all crowded? Is there any? Is there a
bite?
Oh yeah, we're definitely looking at the bite. Those deep bites, those underbites, anything that's blocking function of the tongue and the facial muscles. That's causing this high inflammation. And like you said, sometimes a kid will get sick, and that starts that whole cycle. And so it's really important, if they're always having stuffy noses, always having allergies, not only are we checking those things, but we're saying you got to clean the nose, right? If you can't clean the nose, the next way.
What do you mean clean the nose? Clean the nose with what?
Saline, like nasal hygiene, saline solutions. Right? Just to be able to get all the gunk out, because that's the only way we're supposed to be breathing. We're not supposed to breathe through our mouths. So that snoring is that, you're breathing through your mouth, and you're breathing through your mouth as a survival mechanism, right? But when you do that, you're breathing straight cold air, and it's not humidified, it's not warmed, it's not filtered, and something called nitric oxide is not being made to help vasodilate the body. I'm going science again, but
right, it's through your nose,
exactly. So the nose is made to do a lot of function. It's got our architecture here. The mouth is not meant to do that. Survival, right? If we're like we have to breathe, that's the way to go. But for some kids, that's the way their life starts out, right? And all that inflammation and all of that stuffiness.
Yeah.
So how do parents differentiate from a pediatrician who's saying, hey, don't worry about removing the tonsils, to you guys are saying this is a problem? Does that make sense? How do we differentiate the two?
I'm on the same board. I don't want us to remove the tonsils. We don't need to remove the tonsils. We need to get to the root cause as to why the tonsils got so big and why are we inflamed in the first place.
Okay.
That's what we need to get to the root cause, because they can shrink.
They can shrink.
They can shrink. When they're touching like this, that is your end stage, right? They actually can shrink as well. We've had them do that. But
with your appliances.
Yeah, with treatment, with therapy. So we don't just call it, the appliance is just a tool. The structural portion is structure, function, behavior. So it's the way, if the therapy's going the way it should, things will happen for the body.
And the inflammation goes down. They now become nasal breathers. So the tonsils doesn't have the need to help to filter the air that's going straight into the lungs. So.
Interesting.
And Dr. Horton actually mentioned something earlier. 10,000, 20,000, 40, 50. We all know that in dentistry, there are certain things that not everybody can afford, right? And so everything you guys are saying is really beneficial because, hey, we're trying to prevent this from happening. We don't want kids to suffer and all this other stuff, but the financial aspect still has to be there. And so what do we do when there's a patient or a family that cannot afford this treatment, which is beneficial for them, but they just cannot afford it? What do we do then? Like, how do we solve this problem, right? Because what you're saying is a great option, and it's, like you said, non-invasive, and that's something that you want, but not everybody can afford this. Yeah. And I'm not trying to say solve the world's problem, but we have to talk about
it's a great
people are going to hear this and say, well, I can't afford that. It sounds awesome and I'm excited, but I can't afford this.
Yeah, no, that's a great point. There are some parents that we know for certain that they cannot afford it, and the kids need that. Right. And so we're open. We generally do a lot of pro bono work. And some people, we get a tiered level for their cost. But that affording something is very relative, right? So first of all, for us, we have to get a commitment that you understand what the problem is and that you understand the commitment to it. Because I don't care for somebody to pay us $30,000, $40,000, and they wouldn't do the work that is required for the kid to get well. I've given people money back, and then, no, you're not good for the program, because if you're not helping this child get the help they need, your money is no good to us. Because the joy is seeing that child come in like bouncy and happy and more confident and just being their best version of themselves, really. So yes, and we do have options. We do have payment plans, and that make it easier to fit within the budget. Most of the parents are here long-term as well. They've been here a very long time. So we've gotten stiff a couple times, but God is good. So he makes up for the people who do us wrong like that. And
well, let me ask you this, because when we talk about anything in the mouth, right, whether it's periodontal disease, cavities, we know that a lot of things as far as our health are multifactorial. Right. So knowing that if we're talking about airway and sleep apnea, that obesity is probably one of the biggest things that's tied to that, right? We know it can be size and function of the tongue. We know that it could be sleep positions and habits and so forth. So at what point do you feel like you can say, all right, I got a child that's obese, but my treatment's still going to work, when we know that one of the biggest contributors to sleep apnea and airway obstruction is obesity? So is there any way that you factor out or adjust for other factors that we know the data shows has a greater, proclivity to cause something like airway obstruction, sleep apnea?
So that's a great question, but what I want you to think about as well is that when they start sleeping well, even when you had got your appliances,
Yes.
you lost like 20 pounds.
Just like
So-
Well, that was actually very brave of you to mention that, but we
No,
we don't have to
well,
do that.
you
We
know,
don't have
I
to.
was
fabulous,
actually,
right?
when he was
We
asking that
appreciate the
question-
story.
When he was asking that question, I was looking
Right,
at
that's
online
awesome.
and said,
Right.
I remember
That's
before
awesome.
I had my CPAP, it
Right.
was like triple. Now it's just
Right,
double,
right.
but it used to be triple.
So when you understand how the body works,
Mhm.
right? We now need to understand why are we obese in the first place?
Hmm.
Why is our body not being able to process insulin the way it's supposed to? And then leading, of course, leading you to have bad sleep. But we have some kids who are I guess of larger size, so to speak. They start sleeping well, their body starts working well, right? So
With no changes in anything else.
of course. So part
Okay.
of the pillars is nutrition. Nutrition is extremely
Okay.
important, right?
Mhm,
So
mhm.
we definitely have to mention that. That's the epigenetic force that's also causing all of this that's occurring, right?
Good.
So but you're absolutely right about there being other factors, but that's why we do such a really detailed work on looking at the patient, like what is going on, because sometimes we need to send them to a nutritionist or something of the sort, but we know that and get their gut healthy. So there's a lot of internal physiological things that occur that when the body is out of this sympathetic overdrive and it starts to just calm down, all those things that we're seeing as far as like the body, because that's what the research started to say first, but now literature, actually data is now turning it around to say what the cause of sleep apnea is not always, because you have lots of women, right? You have lots of women who are not obese, right? Who are having what we call the upper airway resistance, which is in a way, yeah, it's the next step to getting sleep apnea, but in a way is very insidious, because it's what's causing anxiety, what's causing brain fog, what's causing weight gain as well, right? From them being skinny or just unable to lose certain types of weight. So you're absolutely right. They're different causes, yes, but being able to do a lot of detailed work. If everything's working well, like posture, everything looks good, then yeah, of course, we're gonna say, okay, only just lose weight. But we know that, like you said, everything is multifactorial. It really is. And everything is connected. The more you research, the more you see, everything is so very much connected that
Right.
we gotta see, why did we get to this weight in the first place?
I feel like I would tell my kid, hey, you're gonna get on the treadmill every day for 2 months before I spend 40 grand on your airway. Let's see if losing the weight first fixes the problem before
Yeah,
I spend 40 grand, right?
Well,
I hear you.
He would say nicer than that, I think.
Yeah, of
No,
course.
not to my kids.
No.
No.
When you talk to the kids, like you just say, you keep it like
Right.
real.
Exactly.
I see this. I see
Right.
this. Let me ask my last question, which is, every time I hear a lot of these things, I always have to kind of be careful and kind of listen with like a third ear, because it almost sounds like the magic bullet. And that brings on a lot of skepticism from colleagues, from society, or whatever it may be. And so I want to make sure that I ask that question is, you're not saying this is a magic bullet. You're saying that there are other, I want you to explain that, because I don't want people to think, I don't want people to think that, you're just coming on and saying,
There's a
you're
lot
selling
of
a magic
work.
potion,
Yeah, we definitely came on and said it takes not just structural, because that's the magic bullet would just be me telling you this appliance is what you need to use to fix your sleep disorder breathing, or to fix your sleep. We didn't even say, we're talking about guiding the growth starting from days old, right? So that it gets harder as we get older. Not only psychologically, emotionally, it gets harder, but also our bodies are set in certain ways. Our compensation patterns are set in certain ways. So now I have to send you to different type of providers. We just like to be the quarterback, right? Because now we're doing such detailed work to see where the root cause is coming from, or where it could be coming from, because we don't know everything, right? We're still dentists that just know a lot about certain things. So it does take a lot of work, but we're seeing that some of our, especially in our area, top level athletes, right, who want to get to a certain level, or singers, actresses, people who are like, no, I have to be able to use my body to its utmost like I have to hack my body essentially.
Mhm.
This is what they're doing. They're doing it from the start, or some of the teenagers are starting, like our athletes, like they're definitely into this because it's giving them a better oxygenation throughout their body so they can be able to use it and use it well, right? Instead of getting injured, right? You know how to brace yourself properly because you're fully stable, your whole body's stable, instead of, you know, having certain types of dysfunction. And I just want to say something about when you said, how can we get this to so many people? People can't afford it. The biggest thing, first of all, parents advocating for their practitioners to start kind of getting up out of their seats and learning this, right? Because the more people who are doing this, then the more the insurance companies, which that's who we're actually fighting. We can't just only put it on the practitioners to
Right.
just giving. We're actually battling insurance companies who want to dictate how things should be treated. And if we treated our patients the way it was in 1970s when preventative care came about, how will we be living, right? So I just wanted to make sure, because I don't want to get phone calls about doing free.
No.
I'm just kidding. No,
We
I
wouldn't
really
do
wanted,
that.
yeah,
We wouldn't do that. We wouldn't do
I
that.
really want it to be a cry for our practitioners as well, because some of the reason why they don't get the care is because the practitioner will see something and not say something.
Right.
Right.
And
And
that
they could
happens.
afford it.
Yeah.
Right.
And that definitely happens in dentistry. That happens in medicine. You know, insurance, I think. And if anybody that's ever watched or listened to me or this podcast will know how much I don't like insurance. So let's put it out there. I'll say that again. I don't like insurance because I think insurance sometimes doesn't give us what we need or want, you know, and I do believe that goes with every insurance. House insurance, I don't care, motor insurance. Whenever you need it, that's when they're usually like silent on the phone, you know. So I get that. You know, Dr. Horton, last question for you, sir. Do you have anything? And then we'll kind of wrap it up with the young ladies.
No, I enjoyed the spirited conversation. I think I would love to see some of the literature, so you guys can just forward that to me afterwards. I think it's important that every aspect of improving, especially children's health in this nation, needs to be explored, because we're seeing obviously an epidemic of a whole slew of problems, not just obesity, sleep apnea, diabetes, and so forth. So any angle that we can attack it from, I'm all for it. So I celebrate the two of you. I applaud the two of you. I feel like I walked away learning something. So I feel this is very educational for me. So I'm sure anyone listening is definitely going to be top of mind, especially from a provider, because we might be the people that catch it that then refer them to you as the people that specialize in this field. So maybe what we could do, Walt, is maybe bring them on back in a few months with maybe a checklist for us. You know, we are fielding a lot of patients. What's something we need to be looking out for? You know, obviously we don't have time to go through it now, but being able to educate us on how to identify children that need to be referred for these type of treatments, assessments.
You know what? This is what we're gonna do, and I guess I was actually gonna bring this up. I was gonna bring this up, but I want to ask them off screen so that they didn't feel pressured. But you know, every Friday we usually put up a case of some sort, right? Different cases, different explanation, going in depth about what we're talking about here. So for you guys, you could come on and just show us your little checklist and kind of break that down so that patients and anybody who listens can actually see this checklist and say, okay, this is exactly what I'm looking for. You know, so that's something, and it doesn't have to be long, 10 minutes or whatever it may be. And we usually post it on Fridays. So if you guys want to do that, we're more than happy to have you guys do that, you know. In the end, the whole point to this is just try to educate everybody, not just dentists, but patients. Anybody that's listening needs to know. I think it's wonderful. I think dentistry, we need to get away from lack of prevention. Basically, what we're doing is we're always fixing. I want us to prevent. And I've said this. I remember the young lady that came on with TMJ. I said the same thing. I'm going to say the same thing to you guys. I think we need to do more preventative than we do more repairs. We're not mechanics. We should be people that try to prevent, you know, the flat tires and the engine blowouts. You know what I mean? So we need to do more of that. Before we let you go, guys, do you guys have anything you want to tell any of our listeners? And then you guys have the last words, so please educate us some more, and then we'll call it a night.
You know, as you were saying that we have to do more to prevent, what came to my mind is what we're looking out to doing, and that is going to for prenatal classes, because the environment where the baby grows also helps them, helps to shape their lives.
Mhm.
So if the mom has sleep disordered breathing or signs of sleep issues, that she's not getting good oxygenation. So her womb is not as oxygenated as it could be, and that can affect how her baby forms as well. So the saying goes, the best time to feed a baby is before they're born, 2 years before they're born. And the next best time is now, right? So being able to talk to, you guys see them as older people, when they come in, they're getting married, they're excited, they can start a family, then you can tell them or give them ways to optimize their own health so that their babies could be healthier. And then we wouldn't have to fix as much either. So.
That's awesome. That's
Well
awesome.
said.
Thank you so much.
Wrap.
You know, honestly, we appreciate the time that you guys took to, to come on this podcast. And I hope that everybody learned. I know I learned a lot. I know Dr. Horton
Indeed.
learned a lot.
Absolutely.
Thank you so much. And we appreciate you guys very, very much.
We
Yeah.
definitely thank you guys
Yeah.
for having us. We thank you for like the rapid fire questions. Dr. Horton, we really appreciate that.
Yeah.
I'm gonna bombard you with just a
Oh,
whole lot of
yeah.
stuff.
Please do. Please do. Looking forward
I'm
to
the
it.
nerd here, like since I'm the one that's learning this stuff, I'm like, oh my God, oh my God, oh my God. So there's a lot to definitely digest and whatnot. So we definitely appreciate Walter, it's been a while. We've known each
It's
other.
been a minute. Thank you. Thank you. Thank you. Thank you.
Thank you so much.
Thank you.